Learn about the critical role of diagnostics by visiting bioMérieux's Medical Education Hub. Watch webinars and tutorials, access online courses, and download educational booklets developed in collaboration with renowned experts. Go to biomerieux.com to begin exploring.
Dear colleagues, I am excited to chair this session on novel approaches to pathogen detection and biomarkers and diagnostics in sepsis. My name is Konrad Reinhart, and it's my pleasure to announce our first speaker, which is Evdoxia Kyriazopoulou, who is trained in internal medicine and critical care medicine and currently practicing in Athens. And she has an extensive track record also in the field of biomarkers in antimicrobial stewardship. Please get started.
So good morning, good evening, good afternoon to everyone. It's a great honor to be part of this year's World Sepsis Congress and talk about biomarkers in sepsis diagnosis and antimicrobial stewardship. Biomarkers are indicators that can be measured of a biological process either in normal or abnormal conditions. And in sepsis, there is a great variety of biomarkers studied so far because the syndrome is quite complex. In sepsis, biomarkers help us to diagnose the septic patient and also early recognize the patient with organ dysfunction. But also, we use biomarkers to guide our treatment like antimicrobial stewardship. For the next 10 minutes, we will focus on diagnosis and antimicrobial stewardship using biomarkers in sepsis. The current Surviving Sepsis campaign guidelines suggest that we should use intensively scores and programs to detect patients with sepsis to early screen for sepsis. And although the sepsis 3 definitions have implemented SOFA as the SOFA score as the gold standard for sepsis diagnosis, the abbreviated score, the Q-SOFA score, is not recommended for sepsis detection because the Q-SOFA score is not sensitive enough. And of course, biomarkers, when adding biomarkers to Q-SOFA, we can increase the sensitivity of the score, and such biomarkers may be lactate or arterial pH or pisepsin. Of course, there is no ideal biomarker to diagnose sepsis, and the most studied biomarker so far is procalcitonin, PCT. In a large trial consisting of more than 75,000 patients in the US, procalcitonin levels on admission could not discriminate bacterial sepsis. PCT levels varied widely, dependent on the pathogen detected and also the origin of infection. And of course, higher levels were shown in patients with septic shock and higher SOFA scores. And the overall sensitivity of the biomarker to detect sepsis was almost 70%, not well enough. An interesting ongoing trial in the UK is conducted in emergency departments and combines procalcitonin, a biomarker, with a NEWS2 score, which is quite sensitive for sepsis diagnosis. So patients are randomized either to be detected with a NEWS2 score or with a combination of procalcitonin and NEWS2. And the two primary endpoints of the trial are the rate of patients that received antibiotics in the first 3 hours and also a safety signal of 28-day mortality. What really matters is not the initial value of procalcitonin, but the kinetics of the biomarker. In a large trial of 500 patients, there were found 3 classes of PCT trajectory. The first class is the high-value slow decrease with worse outcome, and there are 2 other classes with better outcomes: the high-value fast decrease and consistent slow procalcitonin levels. So the current sepsis guidelines recommend that we do not use biomarkers for initiation of antimicrobials, as they are not ideal for the diagnosis, but in order to reduce the duration of antimicrobial treatment to 5 or 7 days, which is a short period of antimicrobials, biomarkers can help us together with clinical judgment. The first trial investigating procalcitonin, or the most wide-studied biomarker for sepsis, was the French Prorata trial. In this trial, patients were randomized either in standard of care treatment or in a PCT-guided treatment with a cutoff value of 0.5. The algorithm was a start and stop rule. So patients received antibiotics when PCT was higher than this cutoff, and also continued antimicrobials as far as these levels were elevated. The aim of the trial was to show that with procalcitonin, the antimicrobial duration will be reduced. And this was the case. But this case was not at the beginning, but the favor of the PCT algorithm was during the course of antimicrobials. There was no reinfection or relapse rate, but there was a signal for higher mortality in long term. This is why the DAT SUBS trial was conducted, having as an algorithm only a discontinuation rule of an initial value, a decrease of the initial value of more than 80%, or an absolute value of 0.5. This is the largest trial so far, which concluded that the antimicrobial duration could be diminished with procalcitonin, but also the investigators came across a very strange and interesting finding that was a survival benefit that was sustained after 1 year. Of course, many meta-analyses have followed this first trial that showed the survival benefit, and most of them also confirmed these results of survival benefit. The problem is that the trials that were conducted until 2016 were all before the new sepsis 3 definition. So all the trials consisted of patients with sepsis 2 definition, and also had a very wide variety of algorithms, either stopping or starting rules with different absolute or relative values. And what is confirmed from this meta-analysis here is that only the stopping algorithm is in favor of survival. Why this happens? Why patients treated with procalcitonin live longer and have better outcomes? It is hypothesized that using the PCT guidance, we decrease the exposure of patients to antibiotics, and less antibiotics means less allergic reactions and less adverse events from antibiotics, such as multi-drug resistance and Clostridium difficile infection. This hypothesis was first tested in a Greek PCT trial, the Progress trial, which was conducted after the implementation of sepsis 3. So patients fulfilled the sepsis 3 definitions and had either respiratory infections or urinary tract infections or primary bacteremia. They were randomized according to the PCT algorithm of the SUBS trial, so discontinuation when the cutoff was achieved, or they were randomized to standard of care treatment. The patients were followed up for 6 months when the primary point was analyzed, and also there was a gut colonization follow-up throughout the trial. Of course, again, the trial showed the use of procalcitonin reduces the antimicrobial duration and also mortality at 28 days, but the primary outcome was a bit different from other trials. There was the rate of long-term infection-associated adverse events, infections from multi-drug resistant organisms and Clostridium difficile. And this rate of events was reduced from 15% in the standard of care treatment to 7% in the PCT group. The rate of gut colonization between the groups was similar. And what is important is that patients that were treated according to standard of care had a higher risk of developing clinical infection when colonized with Clostridium difficile or multi-drug resistant organisms. That was not the case in the PCT group. This higher risk for developing clinical infection when colonized was associated with changes in gut microbiome and also gut barrier function, as shown by the Shannon index of these patients. So patients in the standard of care experienced a decrease in the Shannon index at day 7, which recovered after 28 days, whereas the PCT group had a similar Shannon index throughout the trial. There are not so many biomarkers except for procalcitonin that are studied in antimicrobial stewardship trials and also real-world data, but there are a few trials about CRP. In this trial published in JAMA in 2020, CRP guidance was compared to a fixed duration of 14 days of treatment for gram-negative bacteremia and also for with a fixed 7-day treatment for gram-negative bacteremia. The CRP guidance was non-inferior to 14-day treatment, but could not reduce more than the 7-day treatment, the antimicrobial duration that patients received antimicrobials. The latest trial published in JAMA this year was a trial from the UK in more than 40 ICUs with enrolling patients with suspected sepsis. 3 arms of treatment were tested. The first was standard of care. The second was PCT guidance with daily PCT measurements. And the third was CRP guidance. And it was concluded that PCT could reduce the antimicrobial duration as well as the 28-day mortality, whereas CRP could not reduce the antimicrobial duration of treatment, and also the data were inconclusive for mortality. From meta-analysis comparing the 2 biomarkers with standard of care, we conclude that PCT and CRP, both biomarkers, can help us in our clinical decision to stop antimicrobials and reduce the antimicrobial consumption. PCT seems to provide a survival benefit in contrast to CRP, which is of no benefit regarding mortality, and sepsis recurrence seems to be no problem with both biomarkers, as the rate of sepsis recurrence is similar either if the patient is treated with biomarker guidance or with standard of care. The benefit of PCT guidance is also pronounced in patients with sepsis 3 and also pronounced in those situations and those healthcare settings where duration is already short of about 7 to 10 days. And to conclude, to sum up, with this expert opinion, when we confront a patient with sepsis or suspected sepsis, we have to start antimicrobials as soon as blood cultures are drawn. And if the patient is in shock, of course, we have to start within 1 hour. If the patient is only septic, we can wait for 3 hours. And it helps a lot when you have a baseline value of CRP and PCT. After the results of the freshly published trial in JAMA, with a preference for PCT compared to CRP. We have to follow up our patient every day with clinical assessment, and if the patient is getting better, then we can stop antimicrobials in 5 days, after 5 days of treatment, when the biomarkers are compatible with such a stop. If the biomarker hasn't fallen, then we have to think about alternative diagnosis or multi-drug resistance or something complicated infection that we have to do source control or step up with antimicrobials, or just think another cause of disease. Thank you very much.
Thank you very much for this nice overview. And but so let me ask a question, because you have in your summary still mentioned CRP and PCT in this context. Do you think, given the results that we have seen, that we should use both biomarkers, or wouldn't it be enough to, in this setting, to use PCT? So, and I just wonder how your clinical practice is in this context.
So the summary was an expert opinion published a year ago, and the author suggested that we should use either the one biomarker or the other. After the publication of the trial in JAMA this year, there is a preference to PCT because it seems that it can reduce the antimicrobial duration even in shorter courses compared to CRP. Mm-hmm. CRP alone is not very helpful.
How are you doing at your institution?
Yes, I am doing it. The problem with the biomarkers is the cost. So many clinicians think about the cost, but it has been shown that it is not valuable to measure the biomarker every day. It has the same value if only two measurements are taken.
Every second day, you mean, or?
4 to 5 days.
Okay. So thank you so much. And it's my pleasure now to introduce Professor Thorsten Brenner from the University Hospital of Essen, who is a sepsis expert and also has now, as far as I understand, run several studies on the use of next generation sequencing for pathogen identification, both in terms of clinical effectiveness, but also on cost effectiveness. Dr. Brenner, please.
Yeah, Professor Reinhart, thanks a lot for the kind introduction, and thanks a lot for the opportunity to talk about next generation sequencing for pathogen identification in sepsis. So first of all, how does NGS work? NGS works like forensic pathogen diagnostic. That means usually in real world, you will not find the perpetrator at the crime scene. Usually you will just only find its traces. And that's how NGS diagnostics is working. So you usually do not find the pathogen in blood culture, or very rarely, but you are able to find his traces. These are DNA traces in the bloodstream. And that's how NGS diagnostics is working. So this proof of concept we published nearly 10 years ago in the year 2016. We included 7 patients in total. This was my old hospital in Heidelberg, where we developed together with the Fraunhofer Institute in Stuttgart a special proof of concept. That means that we take blood plasma of our patients, we are sequencing the blood plasma, and then we get lots of reads in the blood plasma. Most reads are human reads. They are not interesting for us, so that these reads are excluded. We are just only looking for the non-human reads, which are usually resulting from the pathogens. And then 2 further steps are following. That means at first we are classifying the non-human reads, whether it's E. coli, whether it's Klebsiella, whether it's Pseudomonas. And afterwards, we do a quantification step so that we get an information how many of the pathogens are in the blood. So we get an information how relevant this pathogen might be for the individual patient. In several pathogens, we do get some resistance information so that we can assign this genomic resistant information to resistance databases so that we get a full report, for example, for MRSA or MSSA. We still have some problems with non-genomic related resistance markers for Pseudomonas, whether the efflux pump is switched on or off. These information we do not get from NGS, but genomic related resistance information can be diagnosed using NGS diagnostics. That it works, we were able to see in 7 patients in my old city in Heidelberg. Since it was working, we further developed a bigger monocentric study called the MERCY trial, where we included in total 50 patients with sepsis or septic shock. It was a monocentric, non-interventional study at my old hospital in Heidelberg, where we wanted to get an impression about the performance characteristics of NGS diagnostics. When we look at the positivity rate at sepsis onset, NGS diagnostics revealed a positive result in more than 70% of patients. When we take all the time points, these were 6 time points within a time frame of 28 days following sepsis onset, NGS diagnostics revealed positive results also in more than 70% of patients. When we compare these results with the blood culture positivity, blood culture is really disappointing. At sepsis onset, you have around about 1/3 of positive results. When we take all the time points together, 6 time points within 28 days after sepsis onset, blood culture is only positive in little more than 10%. And are these positive NGS results plausible? Are this important information for the clinician at bedside? This question was asked to independent experts who looked at all the clinical data and all the microbiological findings in combination with the NGS findings. And all the NGS findings were deemed plausible in 96% of all the findings. And when we would have had these information at bedsides, the clinicians would have had to change the therapy strategy in more than half of the cases based on these NGS findings. And these are, I think, really, really amazing data about the performance, so that we concluded to do another study in a multicentric way. The next step was to do a multicentric but still non-interventional study in a real big cohort of patients suffering from sepsis or septic shock. It was entitled the so-called Next Genesis trial, which was performed from 2019 to 2021 in more than 20 study centers throughout Germany, including more than 500 patients with septic or septic shock. And again, the positivity rate for the NGS diagnostics was 70% as compared to the blood culture with 19% positivity rate. Here we took blood samples at sepsis onset and 3 days later. And again, the plausibility was very, very high for the NGS findings. When NGS real positive results, they were classified as plausible in nearly 99% of cases. And again, in how many cases would have led the knowledge of these NGS findings to a change in therapy? A change in therapy was recommended in more than 1/3 of cases based on the NGS findings, according to the expert's opinion. And based on these amazing data, we then decided to do the last step. We created a multicentric interventional randomized controlled trial, the so-called DigiZep trial, which was performed between 2021 and 2024 throughout more than 25 study centers in Germany, including 410 patients suffering from sepsis or septic shock. And these are quite new data which have not been published yet. The DigiZep trial is a multicentric randomized controlled trial which tried to answer the research question whether we are able to show an outcome improvement in sepsis or septic shock patients through the optimization of the anti-infective therapy based on NGS-based pathogen diagnostics. Concerning the primary endpoint, we chose a combined endpoint, including intensive care unit stay, the consumption of anti-infectives, mortality, and acute kidney injury. And these were all combined to one special score, the so-called DO-RADAR score. This study was a 2-arm study. We had a control group in which the therapy, the anti-infective therapy strategy, was based just only on standard of care microbiology. And the results of this group were compared to an interventional group where clinicians at bedside received standard of care microbiology in combination with the results from next generation sequencing. The study was funded with more than 3 million euro throughout the Innovational Fund and was started in March 2022 in Germany. So what about the results? These data are quite new data, have not been published yet, so I'm very proud to show you these data. And again, the performance characteristics are quite comparable to the previous results from the other studies we had done the years before. Concerning the positivity rate, we were able to show a 4-fold higher positivity rate for NGS diagnostics as compared to blood culture. And this was still more increased to a 10-fold higher positivity 3 days after sepsis onset. That means blood culture is positive in very rare cases. NGS diagnostics become positive quite more frequently. And what about the plausibility? Are the results which we get from NGS diagnostics, are they plausible in most cases? And again, yes is the answer. In the other studies, we had a plausibility of about 95%. And in this study, the DigiZep trial, we had a plausibility of 85% throughout all the time points when NGS diagnostics were performed. And again, I think that more than 80% plausibility for us as a clinician at bedside is very, very satisfying. However, the study was a little bit disappointing when we look at the primary endpoint. We were able to observe a positive trend towards a better DO-RADAR score in the intervention group, but this difference was not statistically significant. When we look at a special modified DO-RADAR score, there was a even more relevant trend towards a statistically significant benefit, but again, it was not hardly statistically significant. And now the big question was, why did we miss the primary endpoint, although we had very, very amazing preliminary data from all the other studies? And then we looked, before I can answer this question, to several secondary endpoints. When we look at these secondary endpoints, we are able to see that there are several really relevant, significant benefits when we perform the NGS diagnostics in patients with sepsis or septic shock. That means NGS diagnostic is able to significantly shorten the duration of ventilation nearly by 3 days. NGS diagnostics are able to shorten the duration of shock in septic shock patients by nearly 2 days. Not even more statistically significant, but we are able to shorten the need for renal replacement therapy by nearly 2 days. The length of hospital stay is shortened by nearly 2 days, and the length of ICU stay is also shortened by 2 days. Some of the results are statistically significant, others are clinically relevant, but we slightly missed the significance level. So now I want to come back to the question, why did we miss the primary endpoint? So we suspected that a change of therapy through the clinicians at bedside should be performed in round about 1/3 of all the cases. And we were very disappointed that we were just only able to show a change in therapy in 12% of all the patients. And then we decided to show all the cases, all the standard of care microbiology, and again, all the NGS results to 3 independent experts in the field, and to ask again, in how many cases would the clinicians at bedside had to change the therapy based on NGS findings? And when we ask our experts, they again say, in 1/3 of all the patients, based on NGS findings, you have to change the therapy. In more than half of these cases, the recommendation would have been an antibiotic restriction to be much more tighter concerning the anti-infective treatment strategy. But in 20% of patients, the recommendation would have been to expand the anti-infective treatment regimen. And when we now look again at the primary endpoint, when we take the expert's opinion, where the experts say you have to change your therapy, and compare the primary endpoint to the patients where the experts say just stay the therapy as it is, then we have a significant change in the primary endpoint based on NGS diagnostics. That means when you do another new technique, you have to advise clinicians at bedsides how they have to interpret the results so that all the results are taken into account for better anti-infective treatment. And when we go a little bit more into detail, and when you look at this Kaplan-Meier analysis comparing patients where experts say just maintain the strategy, or when experts say you have to change, either escalate or de-escalate, you can see that patients where experts say you have to escalate the strategy, where a pathogen is not considered into your anti-infective treatment, these patients have worse survival. Long-term survival as well as short-term survival. And the best survival we do have for patients where experts say the anti-infective treatment regimen is perfect. And that means it definitely makes sense to include NGS diagnostics into anti-infective treatment planning, but you have to teach clinicians at bedside how to interpret these results and how to translate the new findings into your anti-infective treatment planning. Let's go to the summary of my talk. First of all, I have hopefully shown that pathogen diagnostics are an integral component of the guideline-compliant treatment regimen in patients suffering from sepsis or septic shock. I've hopefully shown that blood culture, although it is the gold standard of pathogen diagnostics, is associated with relevant weaknesses, especially concerning the positivity rate. I've shown you that next-generation sequencing-based diagnostics offer really promising performance characteristics as compared to blood culture diagnostics, and represent a completely open as well as quantitative approach. However, NGS diagnostics appear to be capable of improving the outcomes of septic patients, but you have to ensure through an intensive training and a consistent consulting service that the collected NGS findings are consistently taken into account in therapy planning. And then it should work. That's my deep opinion. And thank you for your attention. And if there are any questions, please feel free. And I'm hopeful for a fruitful discussion. Thanks a lot.
Yeah, thank you so much for presenting this intriguing data. I have several questions. Don't you think that you need to do another prospective trial, which will then include what you have suggested, this kind of training. So this is one question. And the other question is, we know that at least about 25 to or 20, between 20 and 30% of sepsis cases are not due to bacterial infections, but to viral infections. And I just wonder, with this kind of technology, you won't get information to this. So how can you then rule out that these patients, the primary cause of was a viral infection?
So coming back to the first question, you're completely right that we need another prospective trial, and this trial is already in planning. We have successfully reached the first funding step of another study for the Innovational Fund, where we will place this new technique in the emergency room. So we will do the diagnostic in suspected sepsis cases already in the emergency room at a very early stage. And in this study, we will include all the things we learned from the DigiSep trial. Means clinicians at bedside will be taught intensively, and every finding will be discussed with the clinician at bedside through an infectiological specialist. Therefore, yes, we are doing another trial where we will provide this new technique for patients with suspected sepsis in the emergency room setting. Coming back to your second question, you're completely right that not only bacteria are able to induce sepsis, and that's the nice thing concerning the NGS-based diagnostic. It's a completely open platform as long as the sepsis-inducing pathogen is a DNA-based pathogen. So we were able to detect fungi, we are able to detect viruses, we are able to detect parasites as long as they are DNA-based. The only problem we do have with RNA-based pathogens. So with this NGS-based technique, we are able to detect bacteria, viruses, parasites, as long as they are DNA-based. And with this technique, we get lots of sepsis-inducing pathogen, nearly everything, but just a lack is existing in RNA-based viruses. That's the problem.
And do you have any analysis to suggest that really on the percentage where the viruses were most likely to be clinically relevant? So have you looked on this data in this respect?
The thing was that we see lots of viruses using NGS diagnostics, but most viruses are just only viral reactivation in critically ill patients, like herpes simplex virus, etc. The classical cases of virus-based sepsis, like influenza, like COVID, we are not able to detect because these are RNA-based viruses. There we need special PCR-based diagnostics, which can be performed very easily in most of the hospitals. And these sepsis-inducing viruses, when they are RNA-based, we are not able to detect. This is a difficulty or a problem of this technique. And in parallel, we do have another problem, that is the detection of the resistance markers, which can only be detected as long as they are based on genetic resistance genes. Then we are able to detect them. That's another big problem of this new technique.
So thank you so much. It's my great pleasure now to call Larissa from the University of California, who is a specialist and clinical partner in USC Davis Center for Diagnostic Innovations. And we are glad to hear about current and novel approaches in this respect. Larissa, please.
Yes, thank you for the kind introduction. So yes, I'm very pleased today to talk about current and new diagnostic approaches to sepsis pathogen detection. I know we covered a bit on PCT already, but just touching a little on biomarkers, and then of course, host response, which is a new exciting technology that is available on the market, but really has much opportunity for implementation. So I would say, as an emergency department clinician, the focus has really been on the problem of sepsis. However, we still need to identify the syndrome of sepsis earlier. And because there's a great number of etiologies for sepsis, not just bacterial infection, we really need to help identify what is causing sepsis in order to better target treatment. So in the United States alone, we have nearly 2 million patients who are diagnosed and treated for sepsis. And currently, the tests we have available are tests looking at bacteremia, and biomarkers. And we can see that actually the vast majority of patients with sepsis present with respiratory infection. We also know from longstanding data that the gaps in diagnosis have significant clinical implications. So for the first 12 hours after a patient presents with sepsis, there is a 1% mortality for every delay of 5 minutes in treatment. So this is a very, very important fact that makes it absolutely imperative that we work on new technologies that can diagnose sepsis earlier. And as an emergency medicine clinician, we really think about sepsis in terms of actionable clinical questions. So what do I do with this patient in front of me? Once I've diagnosed that they have an infection, do I prescribe antibiotics? What additional tests, ancillary tests, do we need to order? And then a very important question here in the United States, where we suffer from so much emergency department boarding and crowding, do I admit the patient or are they safe to go home? Now, clearly, if the patient is septic, they won't be safe to go home. But there are many patients that we're not exactly sure where they are in the course of their infection. And wouldn't it be nice to be able to identify which patients are going to progress to poor clinical outcomes? And then more importantly, how can we prevent that? So today, when I'm seeing a patient in the emergency department, often we have triage labs. Sometimes they're ordered under protocol by nurses. And it feels like you have to order everything all at once and that each test does not inform the next. So it's a big catch-all approach. One can argue that we are overutilizing tests and sometimes not appropriately using some tests. Let's talk a little bit about the tools we have at our disposal. So first, pathogen detection, assuming this is bacterial in etiology. Never mind that we're not typically catching the viral etiologies. So we have a number of available rapid pathogen identification systems. However, these do require culture, a more than 100-year-old technique that really hasn't changed in many years. We also have rapid susceptibility testing, and I've given some examples here, again, requiring culture. Most of these systems rely on molecular detection, and few are really give us the opportunity for direct specimen detection from whole blood. There are some newer technologies and startups that are working on additional tools that can help from identify pathogens directly from blood and other specimens. Some of them are CRISPR-based. There are other technologies that are out there, but they are not yet cleared. Why do we want to identify the pathogen? We really want to move from empiric therapy, which is a best educated guess on the part of the clinician, to the idea of targeted therapy, where we really can support reducing the emergence of antimicrobial resistance and adverse events to the patients from unnecessary or prolonged broad-spectrum antibiotics. However, because sepsis is so deadly, and I showed you the data about the increase in mortality for every few minutes that we don't start treatment, our first step is administering the broadest spectrum antibiotic in order to improve outcomes. So basically, preventing mortality, trying to target prevention of organ dysfunction, and ultimately decreasing the patient's length of stay and opportunities for other complications. In stage 2, we focus on targeted treatment and de-escalation once we have results, but that can take 2 or 3 days. So I won't rehash the presentation on PCT. However, I just want to highlight here that there are some current uses, mainly for these biomarkers, may not be used to decide whether we're going to start an antibiotic, but they may be used to follow the patient. So we can think of this in a very simplistic way. How sick is the patient? What is the likelihood of infection? But once we have this information, for example, if I get a PCT in a patient in the emergency department, does that high PCT immediately warrant antibiotics? Should I admit them to the ICU, even though they may clinically appear well? Can a low PCT rule out the need for antibiotics? I think we saw some data that suggests no, that's not sufficient to eliminate the risk of progression. And if we do predict sepsis, how do we define what sepsis is? Finally, I want to touch on some opportunities with new markers of host response diagnostics. So these are based on reading patterns of mRNA from white blood cells and can help detect any infection, not just those in bloodstream, but other infections causing severe illness, can differentiate viral versus bacterial infections, can risk stratify sepsis in terms of actually providing an idea of prognosis and risk of progression and severity, can predict a response to therapy, and ideally, although we're not quite there yet, would be easy to use with rapid results at the point of care. What do these tests do? So there are a number of different ones. They help with both diagnosis, and some of them help with both diagnosis and prognosis. So Triverity, which is the product that was recently FDA cleared from the company Inflamatics, that help with both diagnosis and prognosis. Some of them just help to diagnose infections. So we already covered procalcitonin, the MEMED product, MEMED BV, Septicite from Immune Express, and Febridex and Lumos. And again, here we can look at that 4x4 table and think, is the patient very sick? Is there an infection? And what we're looking at here, the etiology, is this syndrome not even related to infection? Is there some other cause of this critical illness? For example, pancreatitis, as we know, can cause a sepsis syndrome. And then also, maybe the patient doesn't have a severe infection. And finally, the most important thing is when the patient is at their sickest and we've identified a bacterial infection, that's when we have sepsis. Some of these also do help with prognosis and severity. There's also the new IntelliSep test from Cytovale, which can be, again, lab-based, but can provide a quick answer on the likelihood of sepsis. And some of these products are very specifically sepsis-oriented, and some, such as Triverity, may be broader in their claims. And then, of course, I know there'll be a whole session on this tomorrow. There are other electronic health record AI solutions that can support or integrate this diagnostic testing or come up with predictive algorithms that can help identify patients with sepsis. But really, the bottom line is, even as these new tests come to market, we still have a gap in translating those promising technologies into the patient at the bedside. So implementation is really the most important thing here, and adoption. So if we don't adopt these tests, then we're not going to be able to make the best use of them. So there is a feasibility component. Where is this test best used? Is it in the lab? Is it at the patient's bedside? Let's redefine rapid. For those of us that work in the emergency department, waiting for a blood culture and then doing rapid pathogen identification in AST is not particularly helpful in making a decision for the first antibiotic, and certainly maybe not even the second antibiotic. So we need to redefine rapid in order to support testing and stewardship, not just antimicrobial stewardship, but diagnostic stewardship. And then we need to consider both the host response, which is such an important component in sepsis, the acute inflammatory response that patients have that frequently causes more damage in terms of target organ dysfunction, as well as than the pathogen. Obviously, we need to educate clinicians as these tests come out in the market. Some of them are not going to be that easy to interpret, and leave a little bit of room for subjectiveness, so to speak. And then we need to actually link the use of these tests to improving patient outcomes. So I would argue that for the new technologies I've spoken about, as well as for some of our current biomarkers, we really need to focus on those high-yield settings, such as the emergency department, where we can have an immediate outcome. And then I don't want to forget diagnostic stewardship. As you recall, I presented the ED triage system of order everything all at once. Let's make sure we don't miss anything. And one test doesn't necessarily inform the next, but we could think about, for example, with this Informatics Triverity product, you can see that provides likelihood of bacterial infection, likelihood of viral infection through a scoring system, but also provides some potential information on severity. We could be a little bit more orderly in some of the patients that we would identify at high risk for sepsis. Perhaps we could include additional biomarkers or beyond lactate, a host inflammatory test. And then, as indicated, if we have a high suspicion of bacterial infection, we could do some of these rapid tests, beyond culture, direct from specimen, pathogen identification. And then for special cases where diagnosis is particularly difficult, next generation sequencing is becoming more readily available and lower in cost, but at this point probably should be reserved for patients who are post-bone marrow transplant or have chronic immune suppression or other factors that warrant the use of this test. So what do I propose the future directions to be? I really think we need a paradigm shift. We need more rapid and cost-effective diagnostic tools. We need those to be direct from clinical specimens and not to rely on hours of culture. We need improved identification of the etiology of sepsis, so not just bacterial infection, but also viral infection and other non-infectious causes. Tests that are available at the point of care should have minimal training and less space required for instrumentation. And then finally, we need to implement and incorporate risk stratification tools, and that will include integration with some of the promising AI ML technology that's coming about. And then also, I would say we need ultra-fast drug susceptibility testing, not just rapid. That will actually facilitate targeted therapy in the emergency department. This will improve outcomes, decrease adverse events from antibiotic side effects, decrease antimicrobial resistance in the community, and help preserve the antibiotics we have available now. And with that, I can take questions.
Yes, let me get started. I think all the issues you have addressed are well taken, and this points more to the future or what we need. And I just wonder what you currently use in the emergency department, given what is available, both in terms of clearance by FDA and back and so forth, and also on cost effectiveness issues. But I want to get started just to ask you this question.
Yeah, so I think our options today are limited. As I mentioned, we typically rely on tests that are ordered when a patient presents the emergency department, including, our lactate. We focus a lot on lactate, which is obviously, a marker that we follow based on our metrics for improving patient outcomes. But there are probably better tests out there because lactate is fairly nonspecific. I think, for us in the emergency department right now, the typical mechanism is we actually, I think, identify patients in the emergency department with severe sepsis and septic shock with great accuracy, although we may not know the etiology. And sometimes it's a little harder with the patients that we suspect of having an acute infection, but they appear well at the time. So it's always a question of what to do with these patients. Are they safe to go home? Do they need antibiotics? I think some of the newer technologies can help address this. And really, I think, unfortunately, we're still stuck the century prior. We're really just doing blood cultures and the traditional antimicrobial susceptibility profile. So many of the technologies that I think would really benefit us in the emergency department are not yet cleared. I am interested in the newly cleared technology, the cytovalent inflammatics products. I don't believe they're widely adopted yet since they were, recently cleared. But there is some opportunity to, I think IntelliSup is focused more specifically on diagnosing sepsis, whereas the Triverity test is focused, on looking at all-cause infection and helping figure out, for us, for example, a patient presents to the emergency department and they may look septic, but really it's not clear they have congestive heart failure or chronic obstructive pulmonary disease. They may meet markers for sepsis. And, in those patients, we're worried about a superimposed infection. If we had an ability to distinguish viral and bacterial and to predict severity, we could actually make better disposition decisions and perhaps even avoid antibiotics in some of these patients, that are continuously getting antibiotics and at risk for antimicrobial resistance. So I think there's a lot of promise, but unfortunately we're not quite there yet. And it'll be interesting to see how these technologies get incorporated as, our guidelines are revised.
Yeah, thank you so much. And on your perspective, and which is indeed for the emergency department, what it probably is in most of the departments currently. So it's my pleasure to move forward and to ask Irit Gat-Viks from the University of Tel Aviv on her opinions on the role of biomarkers for diagnostics.
Thanks so much for inviting me to speak in this session. So I also want to thank our collaborators, Michal Netia and Evangelos Giamarelos. Everything that I will describe now is part of our collaboration with them. So just I will start with a general brief introduction to our approach. So generally, if we are discussing medicine without personalized approach, so we get the sepsis patients and we find some drug, and for some individuals it will be effective, for some it will not be effective, or maybe will have even adverse effects. So with the personalized approach, we hope to split the individuals into subgroups, like subtypes, and for each subtype, give a different type of drug, and then it will be effective for all of them. So specifically, we were interested in treatments that are immunotherapy, targeting the immune system, the activity of the immune system to improve the sepsis condition. So the subtypes of individuals that we want to identify, we call them immunotypes because it's not general subtype, but subtype of the immune system. So the focus of my talk will be how we identify the immunotypes that will be relevant to specific immunotherapies. So when started the project, we had several key criteria for the way that we define sepsis immunotypes. We wanted them to be reproducible in many different cohorts, not only in specific cohorts. We want them to be at the molecular level, so we can then afterwards use immunotherapy because it's cell intrinsic activity of the cells. We wanted the immunotypes to capture the heterogeneity within sepsis. So for example, to represent the fact that we have both immunosuppression and hyperinflammation individuals, and also we have individuals that have both immunosuppression simultaneously with hyperinflammation. So to be able to represent all this known heterogeneity in sepsis, and also we wanted the immunotypes to be distinct for moderate infection, because if it's the same in immunotypes as in moderate infection, then it's not specific to sepsis, and it's not specific to the immunotherapy that is needed in sepsis. So these are the key criteria. So we start with the reproducibility. So first we looked at the literature. So there are many immunotypes previously suggested in the literature using a clustering of molecular data or using clustering of clinical data. And we see an illustration of this, that it's actually each one of them is very different. Each immunotype that were previously suggested is very different from the others, and there is a lack of generalization to additional cohorts. So if we have already immunotypes, they are not generalized to additional patients in other cohorts. So what we thought to do, instead of using one cohort to define the immunotype, we took many cohorts together to work with many cohorts as much as we could. So we took 8 different sepsis cohorts from published data and our own 2 cohorts that Fusion provide. We took a lot of moderate infections, 8 different cohorts, also human cohorts, in order to be able to see that our immunotypes are different from moderate infection. And also we took data of in vitro infections so we can compare and support our conclusions. The data is gene expression in general, in all blood or PBMCs or monocytes, also in the single cell level, and also plasma proteins. And these cohorts represent different age groups, gender, different infection sites, causative pathogens. So it's like very representative of the different aspects that can affect the severity of disease and the survival, also the mechanism of disease. So what we did with all this molecular data, we identified immunotypes, and I do not enter now to discuss how we identified the immunotypes, but we test for each immunotype that we generated, we test these criteria, if it's reproducible, the 4 criteria: cell intrinsic, capture the heterogeneity, and distinct from moderate infection. And in conclusion, we got 2 key immunotypes that work the best: the inflammation. We named them after we tested what are these immunotypes. So one of them is inflammation, so that it's increasing to eliminate pathogens, but also in general, increasing in injury or following exposure to toxins. And the other immunotype is immune resistance, meaning that it's specifically immune resistance, not other type of resistance, meaning it's the ability to eliminate specifically invading pathogens, not generally to any type of trigger, but specifically to pathogens. So we have the inflammation, which is more general to triggers, and more specific, the immune resistance endotype. So here are some results. For example, here we pulled all the 8 sepsis cohorts and all the 8 moderate infection cohorts. Each point here is a different individual. In yellow, it's sepsis. In green, it's moderate infection. Y-axis is the immune resistant state of each individual. X-axis is the inflammation state of each individual. And what we see here is that sepsis tend to be more inflammation relatively to the resistance, and moderate infection tend to be more resistance relatively to the inflammation. They are split on the relative level of the 2 aspects of the immune response. Also, you can see with the severity score of sepsis, here it's only within sepsis individuals. Each point here is again 1 individual with sepsis. We see the inflammation and immune resistant state, and we see that severity also tend to be higher, more red, if we have higher inflammation relatively to the resistant state, along the diagonal to the higher inflammation relatively to resistance. So we can take all these individuals, these are the sepsis individuals, and we can group them into 3 groups. The ones that have high inflammation, and then that's group 3, and group 1 or 2 is the relative level of inflammation and resistance, which is higher when we go to higher inflammation relatively to resistance. Group 2 should be more severe than group 1. And indeed, we see that if you do survival analysis, we see that these 3 groups are distinct. So now we can, once we have the endotypes, we can afterwards find the markers, protein level in serum. And now I'm doing this the same for the same groups, but just using the markers. IL-6, IL-8 can be also ferritin for inflammation, and interferon gamma and CXCL9 for the immune resistance. And we see exactly the same results. So actually, you can use the markers instead of the original way that we found them based on a molecular cell intrinsic data. So this is a summary. We have here the entire space of individuals. We get the inflammation state, again, x-axis immune resistance, y-axis. And we already saw that sepsis tend to be higher inflammation compared to resistance. Moderate infection is individuals showing more resistance than inflammation. And also we saw that if the inflammation relative to the resistance is higher, then we get higher severity and higher mortality. So what we can conclude with this? So first we see that individuals that have very high inflammation, they are the hyperinflammation individuals known to be in sepsis. Individuals that have very low immune resistance state, they are the immunosuppression known to appear in sepsis. And also very naturally, we see that there are individuals that have both hyperinflammation and immunosuppression simultaneously at the intersection between them. And these are the most severe individuals, which is also well known. So with this map, we can diagnose individuals based on these markers, and we can understand what's going on and how it can be that immunosuppression can be at the same time simultaneously with hyperinflammation. So we can use it also as a guideline for immunotherapy, because individuals that have higher inflammation will need anti-inflammatory drug. Individuals with low resistance will need pro-resistance drug, and individuals with both will need 2 drugs, a combination of 2 drugs. And you can use diagnostic markers for these immunotypes, as I mentioned earlier, with the ferritin or IL-6 and interferon gamma or HLA-DR on monocytes. So we either block inflammation with, for example, anti-cytokine antibodies, or amplify immune resistance, for example, interferon gamma or IL-7. In fact, we did a clinical trial. We are doing clinical trial now called Immunocept, led by Evangelos. To test this, we use with the same markers that I show here, we use anakinra for hyperinflammation and interferon gamma for low immune resistance. And Evangelos will talk about this and other clinical trials of immunotherapy in sepsis in session 13 tomorrow morning. So thank you.
Yes, thank you very much on this very intriguing data. And indeed, as you have mentioned, this is not quite new, but is still looking at it in a more systematic way. And I think this is helpful. And there have been already finished quite a number of clinical trials who have been based on this kind of concept. And I just wonder whether you have additional ideas or whether this is mostly meant to elaborate and define a little bit more the concept as such.
Yes. So first, the clinical trial that we planned is based on the diagnostic markers. So we give only for individuals with hyperinflammation based on its markers, we give the anakinra, and only for immunosuppressed individuals based on this marker, we give the interferon. So we should get better success. And secondly, this is based on we think that this is related to the activity of the immune cell at the cell intrinsic level. So we hope that this will work. Based on the results of this experiment, this clinical trial, we hope to discriminate between responders and non-responders within each endotype and find sub-endotypes for additional drugs.
And I think this is really important because, as you may also know, that sepsis has been considered as a graveyard of surgical industry because we were not able, or it took some decades to better understand that not one size fits all, so that for some patients, immunosuppression may do harm, others might benefit, and back and so forth. So that, I think, is part of the knowledge that and the learning curve that we had. Yeah, thanks again. I think it was also very important contributions. And now it's my great pleasure to invite Olawale Ajose. I hope I did pronounce your name not too wrongly. Just to get your view from Sub-Saharan Africa and what the ideas and the perspectives is in aspect on novel diagnostics and of course also as a tool to improve therapy, please.
Yeah, thank you. And thank you for having me here today. And yes, you pronounced my name correctly. So I will just be talking about what we see typically as the barriers to introducing diagnostics into Africa, especially diagnostics that are, not your typical lateral flow test, things that are a bit more sophisticated. And so it's a quick summary, right? Because we only have 10 minutes. So what I put on the screen are the 4 main challenges that we typically see when we work on products. And what I'll be doing is unpacking each one in the subsequent slides. So misaligned go-to-market strategy is the first. We typically see that there's then a flawed implementation of that strategy. The third is around local distribution partners. And for folks in the room that, work on the commercial side, they would understand really the importance of having local distribution partners. And the fourth is around the regulatory landscape. So let me just quickly go through each one. When we talk about misaligned go-to-market strategy, what do we need? What we typically see is that, because we're scientists, we tend to think about the product first and really not the market need. And because, as you said, sepsis is very complex, right? And because the market is also so uncertain, these products are typically developed for the high-income market. And so there really isn't an emphasis from the word go on LMIC markets or places like Africa. And so, I think, that is something that we all, we see quite often. And then the impact of that is that, the voices in the room that should be advising on what the needs are on the continent and so on are not there, and we rely on voices from elsewhere. So that's one thing. I think the second thing is, so on the point around the flawed strategy and implementation, things require a lot of resources, right? And I think there's just this concept of we've built a good product, people are going to come, and we don't need to do much. I think what we see is that it's a lot more nuanced, it's a lot more complex. You're working with markets, 54 African countries that are quite unique. And so it's never very straightforward. And so you need to think about what would it take to implement and what are the costs and so on. There's also this notion of I'm looking for the easy way out, right? And the easy way out is I'm going to look for donors that are going to buy my product. I'm going to try and convince, the German government. I'm going to try and convince the US government. I'm going to try and convince Global Fund. And, I guess in this case, sepsis is not really part of the disease priorities of most of these organizations. But assuming it were, right, that becomes the sales target, as opposed to really thinking beyond that and saying, look, the market for these products are beyond what donors are interested in, right? Governments are the ones that are going to buy most of these products. Private sector is also where most of these sales will go. And so as we're thinking about the strategy, we're thinking just beyond selling to Global Fund, selling to the folks like USAID and PEPFAR and so on. And so recipe for success, right? And again, this is by no means exhaustive, but we're just sharing some tips on what we see. So I think starting with, there's no one African market, 54 countries. Francophone Africa is very different from the way the distribution systems work in English-speaking West Africa. And West Africa is different from Southern Africa. And so understanding those nuances will be key. And of course, you can't start in 54 African countries. So what we typically say is that you need to find your early adopter countries. And those early adopter countries could be, countries where there's already a strong infrastructure around the legacy sepsis diagnostic tools. Maybe that's where you want to start. Maybe you want to start where you have strong key opinion leaders on sepsis. I mean, you would need to decide where to start. But the point is that you can't work across 54 African countries, and so you want to start in countries that are catalytic in nature. Also, identifying the right in-country partners that can hold your hands through that implementation journey is going to be key. So I'm assuming many of these will be again KOLs, implementing sites, and so on. But you can also think about non-traditional partners in the private sector that have a vested interest in seeing this sector grow. What else do I want to emphasize on this slide? I think starting your planning early is going to be very important. So what we typically see is that the product has been developed. It's when they start planning. They've applied for, say, stringent regulatory approval in EU or US, and then they start thinking about the Africa strategy. I think from the outset that needs to be baked in. So as you're thinking about your planning for the high income markets, you should also be thinking about Africa at the same time. And what you sometimes find is that some of the action points overlap, right? The stringent regulatory approvals that you would need can also be used in many of these African markets. And so I think there's a notion that they're so different that we need to think differently about these markets, but there are points where they actually overlap. So those will be the main points here. The third is around suboptimal local distributors. So this is an area that most people do not talk about. For you to get your products into, so all of the products that we've discussed today are products that most likely, they require instrumentation, you require service and maintenance. It's impossible to get your products in without having a local distributor. And what that local distributor does is he's your boots on the ground, right? The local distributor has a sales force. The local distributor is engaging with clinicians, hospitals, the ministries of health on a daily basis. So they become your voice. They become your advocates. They're the ones that help you get regulatory approvals, and they're the ones that help you get sales. So if you want to succeed, especially when you're working across 54 African markets, you can't do it alone. You need to find the right distributors. Now, the way you find the right distributors is ensuring that that due diligence process is very thorough, right? Because you have the good distributors, who we call the tier 1 distributors, and you have everybody else, right? So it's very important that you can sift through the wheat from the chaff. So that's one common pitfall that we see. People think they can do it without local distribution partners, or people end up having the wrong distribution partners, or they don't negotiate properly with the distribution partner. The other thing here is the risk, right? There is inherent risk in doing businesses in some of these markets. For example, risk of non-payment. And so you want to identify these risks upfront and bake it into the process. The other thing is the regulatory landscape, and everyone talks about this. And so I don't want to belabor this point, but actually I would paint this in a positive light to say that many countries on the continent now have regulatory processes for in vitro diagnostics and medical devices. And there is now greater reliance, meaning that once it's been approved in certain jurisdictions, they would rely on the dossiers that you submitted in those jurisdictions, right? So the very dire picture that people painted a couple of years ago about the regulatory landscape in Africa isn't as bad as it used to be today. So what are the recipes for success? You need to find a good distribution partner, and you need to rely on advice. I think that's very important. You need to think about, as you think about your distribution partners, financial muscle is very important, right? In many African countries, these guys are not sitting on a pile of cash. So what they do is, and they don't have like, low interest rates line of credit. So they take high interest rates, sometimes as high as 20, 25%, and they need to pass these interest rates to the client. So you need a distributor who is financially, who has the financial muscle, that has the sales force, and also one that you just gel with philosophically. And then courtship is also key. It's a relationship-based business, meaning that, you need to spend time in the field. You need to know these people. They want to feel like they're building a relationship with you. And it's not simply just a transactional arrangement. On regulatory, I think we're stating the obvious here, always have a regulatory strategy. It's a lot more nuanced, again, because the regulators are getting more sophisticated. So we shouldn't just assume that we have EMA, US FDA, everything is going to be straightforward. You need to also find experts that would review your dossiers and follow up. The delay sometimes is just due to backlog, right? These regulators are inundated with submissions. So having someone that can follow up is going to be important. And then connection is key, and that's why you need a distributor, because the distributors also have relationships with the regulators because they submit tons of dossier. They know how to compile the dossier. They can organize scientific advice meetings quickly and so on and so forth. So you need to work with a distributor that also has experience submitting in that regulatory jurisdiction. So I just wanted to leave you with these 4 points. I think the main takeaway here is that the continent is advancing and we see more sophisticated products coming in, but it's also not straightforward because you're dealing with 54 markets. Thanks.
Yeah, thanks so much. I think it was very, very important because this is not only about academics, but we really also as a Global Sepsis Alliance want to assure that high quality products, both in terms of diagnostics, but also in terms of diagnostic and therapeutics, will be accessible everywhere in the world and also in resource limited settings. And I think this was a perfect contribution and based, I assume, on quite several years of experience in this field. And so that's my comment. But just also to you, Dr. Olawale, is there already one of these, from my understanding, it's still in at least Sub-Saharan Africa, blood cultures is not very common options in many areas of Sub-Saharan Africa. And likewise, are they, because we discussed about biomarkers, be it CRP, be it procalcitonin and cytokines and transcriptomic aspects. So is there already one example where one of these biomarkers or diagnostics approaches has made it to some institutions? Or perhaps you can elaborate a little bit on this
Yeah, no, absolutely. We definitely have examples across the continent where you have, I would say in most countries, centers of excellence and just like sophisticated labs that they have biomarker tests, they do sequencing, and so on and so forth. These things are not what you would typically find them is you find them in like reference labs, right? Because they're also used for surveillance. But then there's a triage system, meaning that yes, maybe things are managed empirically, but then when they can't manage a patient, they triage that patient up. Now, I'm not suggesting that things are perfect, but what I'm saying is that they exist, there are tests already, platforms already, and these are sophisticated platforms, and the capabilities do exist. Of course, you need to train more people. And so, I'm fairly confident that if there was a, sophisticated like biomarker for blood culture and so on, that, yeah, it's doable.
Okay, so from my perspective, this was a very important session, both in terms that we really, after some of these markers like procalcitonin are on the market, since 20 years. We have learned a lot over the last years by doing clinical studies and to be more confident now in for which indications to use these biomarkers. And I found it also very intriguing that also in terms of pathogen detections that these next generation sequencing approaches hold quite some promise if we do it right. And as with any other biomarker or a diagnostic tool, it will take time and it's needed learning. This was also the case for procalcitonin, a story that I accompanied over decades, and it was first to develop kind of algorithms and ways to use them and back and so forth. And likewise, I think the learnings in the field of really Theranostics in terms also of use the appropriate immune modulatory approaches also, took at least 15 years, but we are getting closer. And as you know, there are already approval by FDA, not only for emergency use authorization during the COVID-19 pandemic, but also in the aftermath for immunomodulatory therapies that they may be approaching. And this is what we had been looking for 30 years. So I feel that we make a lot of progress and understand more and more. And I'm sure that in 5 years, or perhaps even earlier, the concept of sepsis, which took a long time and which is still not accepted and understood by everybody, but I think we are making progress, and I thank all of you who have in different ways contributed to this enlarging of our knowledge base, and also at the same time to go over boundaries and geographical regions, and that also our understanding, both in terms of sepsis prevention, in terms of vaccination, but also in terms of diagnostics and sepsis-specific therapies has grown. And that's what the GSA and our work is all about. Thank you so much for this interesting session.